Welcome, everyone. Thank you for joining us today for lessons from implementing Self-Help Plus and Assist BI with refugee men in Uganda. We're very excited to have you with us today. Good evening, good afternoon, good morning, depending on where you are today. I'd like to say that over the past 8 years, in partnership with WHO and other stakeholders, Health Right Uganda has supported the translation, adaptation, and testing of the WHO Self-Help Plus tool. Focus on South Sudanese refugees, women and men, Health Right pilot tested the tool and found the intervention to be effective in reducing psychological distress. In partnership with the Ministry of Health, we have, for the last 2 years, implemented Self-Help Plus and Assist BI intervention in West Nile and central regions of Uganda. And the intervention has proved to be beneficial to our clients. In this webinar, we plan to share the Self-Help Plus study findings and detail the integration process of SH Plus into broader humanitarian programming. This is the first of the webinar sessions, and tomorrow's webinar on Friday, December 15th, from 11 to 12 p.m. East Africa time, will be dedicated to the integration and scale-up of SH Plus in Uganda. My name is Dr. Teresa Castillo. I am the Chief Program Officer of Health Right International, and it is my extreme pleasure to be your moderator today. Before we begin, I'd like to acknowledge our primary partners, the Government of Uganda, Ministry of Health, World Health Organization, and ELRA, as well as Makerere University, our core partners on this journey. Before we launch in, I just want to give an overview of today's webinar and go over some quick housekeeping rules and time management rules, as we only have 1 hour today, which doesn't seem like enough, but we'll try to keep to time. And then I will introduce our speakers and we'll go through the presentation for today and allow for some time for questions. So we have asked that all of you keep yourselves muted. And we'd love for you to share in the chat your names and your organization. We want to learn where you're coming from today, so please feel free to drop your name and organization in that chat so we can learn more about you. As our presenters share their presentations for today, feel free to enter your questions in the chat. My colleague Shanice will help manage your questions and will return to them at the end of the presentations. We will have 2 rounds of Q&A today in the last 15 to 20 minutes. And please note that you will be recorded, as we are very eager to document and share this presentation with others. So with that, I will go on to introduce our key speakers today. The first is my colleague Vitsa Toll, who is a professor of global mental health at the section of Global Health, Department of Public Health at the University of Copenhagen. He's an endowed professor of global mental health and structural vulnerabilities at the VU University Amsterdam, adjunct professor at the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health, and senior advisor with Health Right International. He holds an MA in clinical and health psychology, a PhD in public mental health, and was a postdoctoral fellow at Yale. He focuses on multi-sectoral integrated interventions that address mental health and the social determinants of mental health. He's very interested in understanding how research can lead to improved practice and vice versa. We also have my esteemed colleague, Mark Slaku, who's a research collaborator and SH Plus implementation manager at Health Right International in Uganda. He's been instrumental in implementing 2 randomized controls on Self-Help Plus in northern Uganda. He's also led the integration of Self-Help Plus through multi-sectoral partnerships in Uganda and has co-authored several papers that have been published in peer-reviewed journal articles, including SH Plus 360, Novel Model for Scaling Up a Mental Health and Psychosocial Support Program in Humanitarian Settings. He holds a Bachelor of Philosophy and a Master's in International Development. So please join me in welcoming our speakers for today. And we can start. I'll turn the floor over to Visa.
Thank you very much, Teresa. Actually, I think it's Marx who will start us off with the introduction, and then I'll take over from the methods. Thanks.
Wonderful. Please, I'll turn it over to Marx then. Thank you.
Thank you so much, Professor Castillo, for the wonderful introductory remarks. I would like to start by just giving a very brief introduction, background to the SS Pass intervention, which is really built on the fact that across the globe, people are exposed to very difficult and challenging situations, which make them to face a number of mental health concerns. Most notably among these is armed conflict. We're aware the world is experiencing armed conflicts almost everywhere, but the attention right now is focused on the armed conflict taking place in the Gaza Strip. But apart from that, we have armed conflict in Ukraine, in Syria, in Lebanon, and so many other places. Now, all these factors combined with the other phenomena, for example, environmental disaster, displacement, poverty, and interpersonal violence, in turn cause significant mental health problems for the affected populations, making them experience, for example, chronic stress, anxiety, post-traumatic stress disorder, depression, and ultimately the impaired ability of the affected individuals to function as normal human beings. Because current evidence-based interventions are too resource-intensive and rely on a highly skilled labor force, which is usually non-existent in humanitarian settings, most people who are faced with adversity do not actually get the help that they need. As a result, innovative solutions are needed to address these problems. So in the absence of trained mental health professionals, either for direct service provision or for training and supervision of non-specialists, in the innovative solutions need to be developed in mental health that can be delivered without an extensive labor force. As a result, SS Pass has been developed to address these needs, basically to address the enormous gap that exists between supply of mental health professionals and then the demand for care in the community. As you may be aware already, the current conflict in South Sudan, which started around December 2013, had displaced more than 2.2 million South Sudanese into neighboring countries, but also a similar number remains internally displaced within South Sudan. But the country has had a long history of conflict dating back to 1955, during the days of the First Sudanese Civil War. The number of refugees, as you can see, about 915,000 have been displaced across the borders into Uganda. That has a welcoming refugee policy in the sense that the government of Uganda has provided refugees with the right to work, to set up businesses. There is freedom of movement and equal access to government-provided services like education and healthcare, which enhances economic cooperations between refugees and the host communities. Despite all these provisions from the government of Uganda, there are still ongoing challenges for the refugees to secure basic needs. So, 30th November 2023, Uganda had 1,604,813 refugees spread across the different refugee settlements in the country. As you can see, the refugee settlements that are spread across on this map, with South Sudanese nationals contributing to 57% of the total number of refugees in the country. The Democratic Republic of Congo coming second at 32%, and Rwanda coming first on the ladder with only 1% of the total number of refugees that are in Uganda currently. SS Pass has been a product of a rigorous research. We started with the uncontrolled trials. We conducted the controlled trials, which culminated eventually into a cluster randomized controlled trial, which took place between 2015 and 2017. And the results of this have been published by the Lancet Global, as you can see on this paper. We had 694 eligible participants randomized to SS+, which was a treatment group. And then these were, we also had a number of participants, about 363 participants randomized to enhanced usual care, which was a control arm of the study. And the RCT found that 613 participants, representing about 88% of the respondents, completed all the assessments. And by all the assessments, we mean baseline and post-assessment, and also the 5 sessions of SS+, as you shall see in the subsequent slides. We also found that in the treatment group, SS+ had stronger improvements at 3 months, that is after the intervention. We also found larger improvements in the treatment group of on 5 of the 8 secondary outcomes. And then the process evaluation interviews that we conducted after the quantitative data collection found SS+ to be relevant, to be safe, to be acceptable and scalable. And as a result, SS+ has been scaled through a number of humanitarian partnerships in Uganda. We had a data safety monitoring boards to evaluate adverse events resulting from the study. And this board did examine 6 adverse events, and none of them was evaluated to be related to the intervention. SS+ is really a lower intensity psychological intervention that was developed by the World Health Organization. It's used for managing stress and coping with adversity more broadly. It's based on acceptance and commitment therapy. There are 5 weekly sessions lasting 90 minutes each. It's delivered by minimal trained lay providers. So each week, the participants are enrolled into each session in which they learn a unique skill that they're given chance to practice before they're able to enroll into the next session in the coming weeks. So it has got 2 versions. The first version is the pre-recorded audio material that is accompanied by an illustrated self-help book, which reinforces skills and concepts learned through the audio. The intervention is highly scalable as training and supervision of the lay providers takes fewer resources as opposed to training people who are able to deliver this, for example, the trained mental health professionals. It's suitable for large groups as opposed to current evidence-based interventions that reach only individuals or a few groups of individuals. SS+ is able to reach up to 30 people in a single workshop, and all this information is available on the WHO website. SS+ has been preferred other modes of psychotherapy because of a number of advantages that it has. For example, it is brief, and then there's less reliance on trained mental health professionals. As I mentioned before, it's delivered by minimal trained lay providers who are easy to supervise and deliver this through a pre-recorded audio content and illustrated self-help book, which can be used as a standalone product. As opposed to current evidence-based interventions that only address one mental health problem at a time, one manual for SS+ is able to address several mental health concerns, for example, depression, anxiety, and post-traumatic stress disorder. We also have the intervention is also helpful across a wide range of people and settings because it has been tested to have worked in humanitarian settings and non-humanitarian settings, as we have seen through our scale-up in Uganda. The intervention is easy to adapt locally, implement and scale. We have been able to adapt this to suit the context of the South Sudanese refugees in Uganda. We have translated the content into Juba Arabic, and we have been able to implement this and scale this through multi-sectoral humanitarian partnerships in Uganda. And across the globe, there are a number of agencies that are also scaling this up, for example, in South Sudan, where SS+ also is an intervention that is able to reach large groups of people. You realize that current evidence-based interventions, as I mentioned before, reach individuals, only a few groups of individuals. But because of a number of people who face, for example, psychological distress, interventions that are able to target many people at the same time are preferred. The delivery mode is very flexible because it can be delivered remotely, and then an intervention is targeted towards thinking too much. As a result, there is low risk of stigma. We have combined SS Plus and tested this also with ASSIST-BI, and ASSIST-BI stands for Alcohol, Smoking, and Substance Informant Screening Tests. It's also developed by the World Health Organization, and it is used for identification of substance risk behavior in adults. It's brief. It takes approximately 10 to 15 minutes. It can be completed electronically or physically to person-to-person intervention. It takes about, as I said before, 10 to 15 minutes and guided by 11 steps. And it's based on motivational interviewing. We have adopted SS Plus for South-Sudanese men. Our initial pilot focused on both refugee men and refugee women, but we realized that the refugee men were not receptive to the program because they came to the SS Plus weekly sessions when they were often drunk, and then they would be disruptive to their colleagues during the sessions. So we took a deliberate move to drop men from the first randomized control trial, but we did not stop there. We took a deliberate move later on to adapt SS Plus by adding an alcohol-focused component so that men will be able to benefit from this. So this component involves integrating SS Plus, which addresses psychological distress, and ASSIST-BI, which addresses alcohol and substance use. So we went through a number of adaptation processes with the South-Sudanese men in order to make sure that the content is adapted to suit the South-Sudanese refugee men. So we conducted 29 key informant interviews with the respondents, including refugee men, family members of the refugee men, where the refugee leaders and colleagues in mental health and social support. We also conducted 5 site tours just to understand the kind of life that men go through on a daily basis in the refugee settlements, the kind of places that they visit on a daily basis, and the kind of influence those places they visit have on their lives. So we had a number of key themes that emerged during this adaptation process, where we found alcohol use is a common problem, and the refugee men experience high levels of stress. We also learned that men were receptive to stress management skills. As part of the adaptation processes, we conducted mock sessions where we tested one standard version of SS Plus versus SS Plus with substance use examples with a sample size of 12. Then we conducted focus group discussions and in-depth interviews, and a number of useful themes also emerged during these mock sessions. When asked whether the men were willing to participate in a 5th session of SS Plus, that in a 6th session that comprised alcohol use, they were very receptive and said they would be interested in taking part in any intervention that helps them to address their alcohol needs. These were part of the adaptation processes that we went through for ASSIST-BI. We did a rigorous translation of the intervention. We translated all the materials into Juba Arabic. Juba Arabic is a common language that is used by the South Sudanese refugees across the refugee settlements in Uganda. We used a local illustrator to develop the ASSIST handbook, and some of the adapted materials which indicate the kind of substances that are consumed by the refugees on a daily basis in the settlements. Then we did cognitive interviews with the health workers and the laypersons to explore how relevant the content that we developed and adapted was to the context of the South Sudanese refugees. We also try to understand issues of comprehensibility and acceptability of the content in the local context. Once this was completed, we trained the facilitators and made the necessary suggestions during the training of the facilitators. These were some of the adapted materials. We developed a flip book, as you can see on the left-hand side of the screen, the WHO ASSIST intervention book that we developed with the help of a local illustrator. Arua. Then we had some of the adapted materials, for example, the handout, which indicates the most common materials and the most common substances that are consumed by the refugees. And then these were categorized in terms of their risk, whether they were low or moderate or high risk. Thank you so much.
Thank you, Marks. I'm also happy to share my screen. If you want to stop sharing, then I'll share my screen and I can flip through the slides. Thanks so much. So I'll be talking us through the second half of this presentation, and it gets a little bit technical here, and I'll try my best to keep it short and highlight the most important conclusions from the data. But I'm happy to talk more in questions and answer time if you have specific questions about the methodology. I'll try to be a bit quick. I hope you can see my screen right now. Marks, you're the only person I can see. Can you let me know if you can see the screen?
Yeah, I can see.
Yes, we can see your screen.
Great, thank you. Also, Marcela. Yeah, so I think I'd like to explain basically that we did two things, and the first is that we conducted a feasibility trial, and the key element, the key reason that we conducted a feasibility trial is to do a kind of test run. So that means that we do an evaluation to try to understand if we can do a more rigorous evaluation at a later point. So we're really trying to understand if it's possible to conduct a bigger, very difficult study. And the second thing we did is that we looked very closely at the impacts of the intervention, but those cannot unfortunately tell us so much because it's a relatively small sample. So this is really a preliminary stage where we have learned many things, but there's still a larger step to take afterwards. So with that said, we conducted a feasibility cluster randomized controlled trial. The emphasis there is on feasibility. We're trying to understand if a full cluster randomized controlled trial is feasible. We did that with 3 different groups of people. So one group of people received a control condition, an enhanced usable care or EUC condition, where they received very minimal level of intervention. Another group, the second group, received only Self-Help Plus. And then a third group of people received both Self-Help Plus and the Assist BI, as Marks has described those interventions. We screened over 200 people, enrolled 181, and were able to work with 176 people in doing a baseline assessment. At the end of the study, when we had completed the interventions, we were able to follow up with interviews with 159 people, so a bit more than 90% of the people we were able to track for interviews. And we included people who were male, as Marks described, who were South Sudanese refugees, adults, and experienced at least moderate psychological distress, and in some cases, moderate alcohol or other substance use, right? That's the Assist BI group. So for the third group, they had to experience both distress and alcohol concerns. We did not include people who experienced very severe alcohol or other substance use concerns, who were not 18 years or older, did not speak Tuba Arabic, or were experiencing psychosis or were at imminent risk of suicide. So we randomized villages and not individuals. That is an important thing to remember. The screening was done using the Assist. Marks talked about the Assist, as well as the K6, which is the Kessler 6, which is a short questionnaire of 6 questions that asks about distress. We tried a few different ways to recruit men, to bring them into our activities. And the best way was to go door to door and talk with men in the households where we went to. But we also tried out other places, so to go where men tend to gather. Yeah, at those places, men were not so excited about talking with us about their concerns. It was much easier to do it at their homes. In terms of feasibility, I think a good thing to keep in mind is that both Self-Help Plus and Assist BI, the brief intervention, are low intensity interventions. So in terms of supervision, it's much less intense than what you would do in a psychotherapeutic or counseling intervention. What we did in terms of supervision is that the lead facilitator led debrief sessions, and everybody shared notes about their experiences. We had quarterly observations to see how things were going. We were tracking competency of the facilitators, and were supporting facilitators if there were cases with people who needed more intense support. The support was delivered remotely, and as Mark's noted, lay providers were the implementers, and where needed. I think that's important. It's a low intensity intervention, but you still meet people who need more intense support. So we made sure that that support was provided where necessary. So as I mentioned, in terms of results, the key things to look at is whether we are able to do a larger study in the future. Those are the key things we were looking for: the accessibility, or the acceptability, and the feasibility of our study and intervention procedures. Those are the most important things to look at. But here you can see a distribution of how things looked for people mental health wise when they entered the study. So you can see that for the largest group of people, alcohol is the larger concern, together with tobacco. We did find groups of people also mentioning cannabis and stimulants, but the largest groups of people really were drinking and smoking. In terms of feasibility of the intervention, it's important to look, of course, at if people come for the intervention. And in terms of retention, we were quite happy with the results. As you may expect, I think we all had fears about how it is to work with men in a mental health intervention. I think they are considered very difficult to engage and difficult to retain. Yet that was not something we found in this study. Overall, we found that men really, after losing a couple of people in the beginning, most of the men tended to come for all of the 5 sessions. So I think, as you can see, where it says baseline, we have 31 people in the first group, 29 in the second group, 27 people and 29 group in the combined intervention. And you lose some people after the first session, but then it tends to stay pretty stable. So that was, I think, good news. Then another thing to look at in terms of our research results is if our research tools are working, if they measure things appropriately. And one indicator of that is the internal consistency of the measures. That is an indication of how questions within one questionnaire are related to each other, if they tap into the same kind of problem, for example. And you tend to want to see in the right column where it says Chromebox Alpha, you want to see a figure of 0.7 or higher. And you can see that that's the case for all the measures. So we were happy with how the research tools were behaving. that's a good thing to see for future studies. Another something that's really good to see is whether questionnaires are able to show change. Some questionnaires are not very good at that. They tend to give you very stable scores over time, even though somebody may be changing on their mental health. And so before going into a rigorous big study, it's good to know if measures and questionnaires are actually sensitive to change. So this table gives you a sense of sensitivity to change. It also gives you a little sneak peek into whether we can expect some promising results from a future study. But again, we can't take that too serious because there are too few people in this study to say anything very substantial about that. But the indications are good. Overall, we can see that if you compare people who received SH plus with people who received the control condition, that there are more improvements in people who receive SH plus. That's what that minus 4.76, for example, means. And if you do not see a 0 in the thing between brackets, it means that there is a significant change. And yeah, again, we can't take too much from these findings, but overall, we can see that there are promising findings with regard to psychological distress, well-being, depression, post-traumatic stress complaints, well-being, psychological flexibility. With the total score, we don't see a statistically significant change, but we see a very promising quantitative change that I think with more participants will end up being significant, and the same for alcohol. It's a very similar picture in the group. If you do a comparison between people who received Self-Help Plus and Assist with the control condition, you see a very similar picture. I think what we would have expected to see is much bigger changes in the Assist group with regard to substances, but we don't necessarily see that here. But that's something that we could think about for future interventions. Maybe we need to give more space between interventions, or maybe we should increase the intensity of the intervention or reverse the order. There are things to think about there. But in terms of the feasibility of the study, these are all good things. So in conclusion, in terms of feasibility, we were able to meet with men. I think many of us are worried about the possibility of engaging men in mental health interventions, but in our study that really was possible. It was possible to meet with men again to conduct the interviews. Supervision was very doable and with minimal needs. And we made sure, that's what the no contamination means, we made sure that people stayed within their study conditions. With regard to the outcome measures, good psychometric properties, good internal consistency, acceptance convergent validity. Happy to talk about that more. I didn't show a table that demonstrates that, but that was the case. And we need to keep in mind that it's a small sample. In terms of lessons learned, I think I also didn't show a table with that, but we saw some differences in how these groups looked across the 3 conditions. And that's something that needs to be fixed for a future trial. It could help to include more villages, or we can balance villages. There are research ways to address that problem. The men were highly mobile. So Marx and his team tend to be extremely good at following up with people in different locations. So with the right team in place, you can follow up with men, but they do tend to move around a lot. So that's good to keep in mind. And as I said before, door-to-door recruitment worked better than trying to find men in community spaces. So in terms of acknowledgements, we're extremely grateful for the assistance of the refugee community in partnering with us and making this study possible. We collaborated with the government of Uganda, Office of the Prime Minister. They provided permission for us to do these studies. The Ministry of Health was a close partner on the study, as was the World Health Organization. And Ken is in the meeting. So if you have things to add, please do, Ken. LRAP provided funding for the study, both R2HC for this particular study and the Humanitarian Innovation Fund for another effort focused on scaling up. UNHCR was part of the study team. We're very happy for the support of the Refugee Welfare Councils, who guided us at different points throughout the study. And we're very grateful to the support and companionship of humanitarian agencies in Rhino Camp, Mvepi, Kiryandongo refugee settlements in Uganda. So with that said, I hand it back over to you, Teresa.
Thanks, Vita. And now we move to our discussion portion of our webinar. We encourage you, please, to share your questions in the Q&A tab at the bottom of the screen. If you don't see a Q&A tab, you can also use the chat. We'll find it whichever way we can. But I think there has been a lot shared by my colleagues, Marks and Vitsa. Enough for fodder. So, but perhaps at this moment, we can start with a general question while giving you time to add your questions in the Q&A tab or the chat. So the first question I have for our panelists is about the study findings. When you consider the lessons learned that you just shared in the study findings, what would you say are the next steps for HealthRay to take in terms of scale up and uptake? What does success look like now that these phases have been completed? That's to either one of you, Marks.
Yeah, Marks, would you like to start?
No, go ahead.
Sure. Yeah, so we've done quite a lot of work on SH+. We have already in the past completed a randomized controlled trial with female refugees. That study showed that SH+ was effective in reducing psychological distress. So very promising results already with female refugees. On the basis of those findings, we have conducted a scaling up project to better understand how we can actually deliver Self-Help Plus at scale. The main methodology we have wanted to do that, as Marks explained, is because that's what he directed, is through integrating Self-Help Plus into the work of humanitarian agencies across very different types of sectors. So tomorrow, the webinar will focus on that, as you can see on the screen. So more will be said about that tomorrow. But this was a study that we really wanted to do to see how we could reach men. And so I think a logical next step from a research point of view would be to do a full evaluation of Self-Help Plus and the assist intervention with male refugees in a larger study so that we can say with certainty whether those interventions are effective. That brings up a dilemma because Self-Help Plus is already an evidence-based intervention. It's also been trialed in evaluations in Europe with male refugees. So I think we can safely assume that it's an effective intervention also with male refugees. And Assist BI has, like with similar interventions like Assist BI, been evaluated in other studies. So there's a dilemma there. Why would you evaluate evidence-based interventions? And I think the key reason we would really like to do that is to address a major research priority. We HealthRight has recently led a consensus-based research agenda setting for mental health and psychosocial support research. And one of the key research priorities that came out is that we need to better understand how we can integrate interventions. And unfortunately, mental health interventions have often been implemented separate from substance use interventions. There have been two different worlds engaged with delivering and doing research on those kind of interventions. And I think it's really important that we start thinking about integrating interventions. And I think with male refugees, that is even more important because, of course, men's mental health is important in its own right, but in many patriarchal societies, men's mental health has a knock-on effect on spouses and children. If men are highly distressed and drinking alcohol, there is a higher risk for gender-based violence. There's a higher risk for livelihoods concerns in families. There's a higher risk for child abuse and maltreatment in families. And so in that sense, we want to understand better how we can improve mental health to achieve a whole range of other social outcomes, including reduction in gender-based violence and improvements in livelihoods. So that's another integration kind of question. So just to summarize, I think a really important next step is to do a larger study on these kind of combined interventions to also better understand how we can improve a range of social outcomes that are related to mental health.
Thanks, Vita, for your reflections and one of the most important ones are around integration and how that can evolve in the coming years. I think post-COVID, I guess we're in pseudo post-COVID because COVID's still around, but certainly the issue of mental health has come forward in a way that it hasn't in the past, and the need for integration is even more salient. Marks, do you have any additional thoughts that you'd like to add to next steps and what success looks like beyond these initial studies?
Yeah, thank you so much. Just two things in summary. One, there's enormous potential for integration of SS+ into other humanitarian programs, but also just like Lucy has mentioned, we have a little bit of evidence to prove that SS+ combined with the CSPI is effective, not only reducing psychological distress, but also in reducing the undesired effects of alcohol and other substance use. So much as we have done this through a feasibility randomized control trial, the results have been promising, but we would like those results to be brought through a fully powered randomized control trial. Thank you.
Great, thanks, Marks. Another question that I had before we go to the group discussions, group questions, is about the design process. And I'm wondering if you can share more about the design process and how gender factored into the development. This was, there were two different studies, one dedicated to women, one dedicated to men. Can you speak more about how meaningful that difference, segregating, how meaningful that was and what that means going forward?
Yeah, happy to jump in. Marks, would love to hear your perspectives, obviously. I think gender featured into mainly that we provided separate groups now for men and women. So in the beginning, in the very beginning, when we had just translated the materials, we had a very first tryout. And we piloted one group with women and we piloted one group with men. And the group with women had some difficulties, but overall, the women were very engaged and they were in problem-solving mode. So if somebody didn't speak the language so well, people would sit in couples and they would talk together to overcome any language barriers. With the men, it was harder. So with the men, some people showed up drunk, some people started talking through the tape, and that was a key difficulty. And we decided at that point, well, we unfortunately we had limited means and we had limited time, so we decided in that time to focus our remaining research efforts on female refugees. I think from a gender equity point of view, that was the right thing to do. There were many more women in the camp. The Rhino refugee settlement is inhabited primarily by women and children. Men make up a smaller demographic group in those settlements. And women, of course, have suffered enormous adversity, including sexual and gender-based violence systematically as part of the conflict. And there are high rates of gender-based violence also during the migration journey and after the migration journey. So we felt it was a good decision at the time to focus on female refugees initially. But as I already explained, men's mental health has an important impact also for women and for men's families, in addition to, of course, being a key concern in its own right. And so we felt it was really important to follow up and identify further funding to understand how Self-Help Plus could be adapted for use with male refugees. Initially, our plan was to adapt Self-Help Plus for male refugees and do a randomized controlled trial within the same study. That's what we applied for funding for, and those were our plans. Unfortunately, what we found is that if we do not address alcohol misuse, which is a very gendered concern, it's a very male concern, unfortunately. If we don't address that, we're not going to have a lot of impact with Self-Help Plus, because a key part of Self-Help Plus is to be more open to your feelings and to be more accepting of your feelings, not accepting of your circumstances, but accepting of the feelings that arise in circumstances. And so we thought it's really important to not just run Self-Help Plus with male refugees, but to add an alcohol component and to test that alcohol component so that we could respond better to men's specific mental health needs. So those are some of the gendered concerns that featured in our decisions as we've gone through these different phases of the project.
Thanks, Vita. Marks, any reflections that you'd like to share? I think his screen is actually frozen. So perhaps we can move to Shanice, who is fielding questions from our audience, and maybe we can take the first three, if you can group the first three, and then we'll do another round.
Yeah.
First two or three. Yeah.
Yeah, sure. Let's go. We can go with the first three questions that we have here. So first, it tends to be difficult to recruit men into studies like this. Do we have any reflections on why we were so successful here with recruiting and retaining men into this study? The next question, should I read through all of them? All right, so then the next question we have, could we also highlight how and if it is possible for us to use this intervention on adolescents, both within a school setting and outside of a school setting? And then the final question for this round, what are some of the challenges that we faced and how did we manage them?
Great, thanks, Shanice. All really good questions. I think the first one we touched on briefly about men, but there's definitely more to explore there. I believe Mark's dropped off and is rejoining, but while we get him back in the spotlight on Zoom, perhaps we can start with your response, Vita, to any three of those that really call out to you in this moment.
Thanks. Yeah, I think actually Marx has returned. So Marx, Maybe we can
Of
start with the
course.
question around which challenges we faced, and you faced many of them, and how you overcame them.
Yeah, thank you very much. Sorry, I dropped off because electricity went off in this country. We first made one significant challenge in the course of the study, and that was in regard to the mobility of men in the settlements. You find that men in the settlement are so mobile that today you come for example, baseline assessment. You are coming after 5 weeks for cost assessment. You find the individual has relocated to the next settlement or has gone back to South Sudan. So this posed a very big challenge for us. But how we managed this was we had a very good tracing contacts. We managed to get contacts of the refugee leaders, with the family members of these participants, so that we could ask where through the close contacts where this individual probably might have relocated, so that we were able to follow up these people, and that's why we managed to get the retention levels that it's projected earlier. Thank you.
Mark, do you maybe also want to say something about why was it so much easier than we expected to engage with men? Do you have any explanations for that? Because it is quite surprising, right? It was much easier to recruit and retain men in the study than we initially expected. Do you have thoughts about that?
Yeah, thank you very much. Initially, the separation of men and women was not part of the design, but it became an important aspect of the adaptation process because of the reasons that this explained. Because we found that in addition to psychological distress, which will be addressed by SS+, men had an additional problem of alcohol and substance abuse, which could be addressed through AssistPI. Then we decided to integrate SS+ and AssistPI to address this problem. But when we ran the mock census, we discovered that men were actually interested in the intervention that focuses on alcohol and substance use, because this was a big problem for many of them. And when they found that this was very interesting for them and it would help to change their lives, they became interested to participate in the program. But also we employed very flexible recruitment methods. For example, recruiting them door to door, moving to places where they gather. So, and this made us to really approach them in places that were very convenient for them. And then later on, they got so much interested in the program and participated in it up to the end and produced the desired results. So it was, first of all, because of the interest that they had shown in doing something about the alcohol problems they were experiencing, and then to the approach that we used to engage them.
Great, thanks, Marks. One of the other questions that was asked was about adolescence and whether or not this intervention could be used with in-school adolescents or out-of-school youth. Any reflections about how we could use this tool with another population?
Yeah, it wasn't designed for adolescents. And so I feel a bit out of my depth on that question. There have been many other MHPSS interventions developed specifically for adolescents. Just, a spontaneous answer without a lot of research data behind this is that I personally think that for older adolescents, some of the content could be adapted and could be very relevant. But that for younger adolescents, it may be a bit harder to engage with the materials. But it would be really interesting to see if there are others on the call who've thought about that more systematically than I have.
Yeah, and certainly we invite others who are attending to share their remarks in the chat. I will reference that Ken dropped a link to Self-Help Plus and the various translations of Self-Help Plus. So thank you, Ken, and please take a look at that link as well. We are coming to the last 4 minutes of the webinar. So I just wanted to do a quick round of the last remaining questions to see if we can get some responses in. Shanice?
Sure. Some of the questions grouped together for our final few minutes here. First of all, what was the impact of the 15-minute alcohol session on actual alcohol use behavior? We're also wondering if this is something that can be used within a development setting. And following what we had just talked about, I think this question may have been answered to an extent. We have a question wondering if Self-Help Plus 360 can be used for the psychosocial support of teen mothers with depression. And then a final thought before we close out, are there any ways that individuals can get involved with this project? Is there a way that they can help raise awareness? Anything that can assist?
And maybe, and maybe if I can ask you to keep your remarks brief so we can try and stick to time.
Marks, do you want to go ahead or?
Yeah, I think go ahead, Peter.
Yeah, so in the interest of time, super quick replies. The first question on whether a 15-minute intervention can give changes on behavior. We don't know. This study was not designed to answer that question. Other studies have shown quite promising results for brief interventions. So the answer is that we don't know based on this study, but yes, quite likely based on other studies. If the SH Plus could be used in the development setting, yes, I definitely think so. And in fact, we are also looking at Self-Help Plus in high-income countries. So I think it's a very widely usable intervention. I think for teen mothers, I don't see why not. There are probably some adaptations necessary, but these were mothers, and many of them were in their teenage years still, right? 18 and 19-year-old mothers, and we didn't see any impact of age on people's ability to benefit from SH+. So I don't see why there would not be a reason that could work out. In terms of if you can help, yes, please, we welcome all collaboration and support. What is easiest? Navaraj, maybe people can write to you as the Director of Mental Health at HealthRight International, and then we can see how we can partner together.
Yeah, true. Good suggestion, Huiche. Thank you.
Great. And Marks, any thoughts or reflections that you'd like to share based on the questions?
Yeah, in regard to the first question, just like Lisa mentioned, we really don't know. The study was not designed to find out, but in terms of whether this can be effective for teen mothers, I think yes, but unless adaptations may need to be made in regard to that particular context. But as this has mentioned before, we have a number of people in that category who have benefited from this before. So we really think that it's workable. Thank you.
Well, thanks for your final remarks. Any last thoughts that you would like to share before we conclude today? We're 1 minute over, but maybe we could still take the time just to allow for our speakers to have any last remarks to share. Maybe we can start with you, Marks.
Yeah, thank you very much. I'd like to give a round of applause to everybody who has been able to make time for this important webinar. Like we communicated before, we have another webinar coming up tomorrow on SS Plus 360, which outlines steps for integrating this novel intervention humanitarian programs we welcome you for that. And like we mentioned before, SS Plus has enormous potential for uptake and integration. Those are my last words for you. And thank you so much. Have a nice evening. Have a good morning, depending on where we are. Thank you.
Thanks, Marks. Vitsa, any last words?
Yeah, thanks very much. Thanks, Marks, for being a fantastic team leader and making all of this possible. Thanks to the SH Plus team in Uganda for all the enormous hard work. And I feel that this is just the beginning. We've now found out that this is an effective intervention. We'd like to learn more about how it works with male refugees. We worked with a number of agencies to see how we can scale the intervention. So we're really ready to partner and increase the availability of Self-Help Plus for people who can benefit from it. Thank you very much for joining today.
Thank you, everyone. Thank you, Vitsa. Thank you, Marks, for the great presentations and sharing your expertise today. As we said, please consider joining tomorrow for the webinar entitled Facilitators and Barriers to Implementing SH Plus 360 in Uganda. And happy holidays to everyone and happy new year. Thank you once again to all of our partners, the refugee community, refugee welfare councils, humanitarian agencies in Rhino Camp, Mvipe, Kiryodongo Refugee Settlements, UNHCR, Makerere University, MOH, WHO, and ELRA. Thank you again and have a wonderful day.